Good morning. Thank you very much for inviting me at such wonderful place and such wonderful meeting. I will start with one of the most challenging presentation, the Year in Diabetes Review. So I'm gonna tell you a real story, and I'm going to start with my name. You heard my name is Doina Catrinoiu, coming from Romania. And you have here a wonderful casino which represents my town and the hospital where I work. And I'm speaking about this story because this story started in 2008 when FDA asked for some important cardiovascular outcome trials in diabetes. So that was the moment when the story started and changed the way that we look to diabetes. Of course, everybody knows about prevalence in diabetes. No doubt that it is something that worries us very much. IDF showed that in 2017 there were 425 million of people living with diabetes, and this means one patient in 11 persons. Seems that the things go on, and the estimation for 2045 is that one adult will have diabetes from 10 people. Of course, we are very worried about cardiovascular disease in diabetes, and this is because this is the most important cause of death in diabetes. And if we compare the patients with diabetes and the matched control, we observe that people with diabetes lost a lot of years of life because cardiovascular disease. And this is something that we cannot control, and it's not something new. We have all kind of drugs for diabetes, but till now, all we could do was to control diabetes, but not cardiovascular disease. So heart disease is a cause of death in more than 2/3 of people with diabetes aged 65 years or older. It was a great impact of CVOT on the evolution of the guideline for type 2 diabetes. And we know this because we face most of the time with patients having cardiovascular disease. Between 2013 and 2015, a lot of cardiovascular outcome trials were communicated, and you know about Examine, ELIXA, TECOS, and SAVOR. And all these were done with this class of drug, DPP-4 inhibitors. What shows these trials? Shows that DPP-4 inhibitors are safety, but they don't protect the patients with diabetes for cardiovascular disease. As you see, the heart ratio for almost all of this study was 1, meaning that there is no difference between the study group and the placebo. How was the management of diabetes in 2015? It is not far away, but it was the moment when the physician was focused more on glucose control. So after metformin, there were 6 options, and the physician could choose one of them. It was sulfonylurea drugs, TZD, DPP-4 inhibitor, CLG2 inhibitors, GLP-1 receptor agonist, and of course insulin. So it was most important the glycemic control than the cardiovascular disease. But the impact of glucose control on cardiovascular complications remained uncertain. We can say that in 2015, The general approach was that not any specific preference for the second line of therapy. What happened with guidelines? Of course, at 2016, Diabetes Care showed that the DPP-4 inhibitor, most of them are safety for cardiovascular disease, not protection, with one exception. It was in Savotimi, which saw that saxagliptin increased the hospitalization for cardiac failure. The next year, in 2060, three very important trials came, SUSTAIN, LEADER, and EMPA-REG, who changed really the way that we look to diabetes. Why? Because these studies show something very important. Show that the patient with 3-point MACE, which was cardiovascular disease, non-fatal myocardial infarction or stroke, were improved in the patients having the study drug compared with placebo. And this was with LEADER, also we SUSTAIN, the two drugs from GLP-1 receptor agonist, and also for EMPA-REG, where the results were amazing, showing decrease in events with 14%. Of course, what was important was that not only glycemic control or patients with events had a positive impact in LEADER, but also it was a composite renal endpoint, showing composite renal outcome was microalbuminuria, doubling of serum creatinine level, or IGFR less than 45, end-stage renal disease, and 4 deaths due to end-stage renal disease. And the study showed that liraglutide improved microalbuminuria in patients with diabetes. Also in EMPA-REG outcome with empagliflozin, it was a composite renal outcome, showing also that this drug can protect the kidney in patients with diabetes. In fact, not all glucose-lowering agents achieve renal protection. And as you see, some of the DPP-4 inhibitor decrease albuminuria, also GLP-1 decrease albuminuria, but the class that protect really the kidney was the CGLT2 inhibitors. About cardiovascular death, it was impressive in the EMPA-REG, the impact of the drug on this endpoint. And as you see, the hazard ratio was 0.62. That's why label updates for empagliflozin after the study, after EMPA-REG. So in 2060, the empagliflozin labels were updated for reducing the risk of cardiovascular death in adults, patients with type 2 diabetes and established cardiovascular disease. Then going on to 2070, we see that the recommendation is in patients with long-standing uncontrolled type 2 diabetes and established atherosclerotic cardiovascular disease, the recommendation was for empagliflozin and liraglutide. Things go on, and another two studies appear. It was EXCEL and CANVAS program, and it was important that CANVAS program also show a decrease in cardiovascular events in patients with diabetes with 14%, but DEVOTE and EXCEL was not very impressive in this outcome. So in 2017, the liraglutide were updated to include evidence from LEADER trial, and it gained the indication of reduce the risk of cardiovascular death in adult patients with type 2 diabetes and cardiovascular disease. For semaglutide were also very good opinion, but it was only an approved pre-trial. So in 2017, European Society of Cardiology adopted a position paper, and in 2080 the things were changed because other EASD consensus report changed the opinion of the leaders in choosing the treatment for diabetes type 2 and cardiovascular disease, or in patients with cardiovascular risk. It was in standard of care a recommendation that in patients with type 2 diabetes and established atherosclerotic cardiovascular disease to choose empagliflozin or liraglutide. And also, it was a recommendation for canagliflozin in patients with type 2 and established cardiovascular disease. It was the first time when the European Society of Cardiology have a position statement concerning the heart failure, because the results in these trials were very important on cardiovascular failure. And it was decided that GLP-1 receptor agonist and DPP-4 inhibitor, like sitagliptin, have a neutral effect on the risk of heart failure hospitalization, but CGLT2 inhibitors like empagliflozin and canagliflozin demonstrate a significant reduction in the risk of heart failure, hospitalization and death. And another studies come to show us that the paradigm in diabetes is changing from a glucose-centered to a patient-centered approach. And this was the first thing that we have to focus to assess the key patient characteristic and to choose the treatment together with our patient. So it is not a treatment for diabetes, but it is a treatment for a patient with diabetes. And of course, you know very well these approach concerning glucose lowering medication in type 2 diabetes. And as you see, there are 4 columns. The first one is for patients with established atherosclerotic cardiovascular disease or chronic kidney disease, where the recommendation is for after metformin in patients with not in target, for GLP-1 receptor agonist with proven benefit, or CGLT2 with proven cardiovascular benefit if the eGFR is adequate. Concerning the heart failure and the chronic kidney disease, the recommendation is that the first line of therapy after metformin is CGLT2 inhibitors, and if they are not tolerated or they have contraindications for this class, to choose a GLP-1 receptor with proven cardiovascular benefit. The second line is for the second column was for patients without established atherosclerotic cardiovascular disease, and as you see, it's something that looks like in 2015. You can choose one of the classes, but the preference is still for new classes of drug like DPP-4, GLP-1 receptor agonist, CGLT2 inhibitor, or TZD, taking in account the level of hemoglobin A1C and the comorbidities of the patients. And the third column was for patients without established atherosclerotic cardiovascular disease and kidney disease. But if we want to minimize the weight gain or to promote weight loss, it was a special recommendation also for the two groups of drugs, GLP-1 receptor agonist and CGLT2 inhibitors. So when we choose the medication, we can choose it concerning the evidence of benefit, which for GLP-1 is stronger for liraglutide than semaglutide and exenatide, where the results were less certain. And if we speak about CGLT2, the order is empagliflozin and then canagliflozin. Of course, in patients with established heart failure or chronic kidney disease, it is obvious that CGLT2 is preferred over GLP-1 receptor agonist because showing in the study consistent decrease in hospitalization for heart failure. And we can say that, of course, it was an important change in our approach to persons with diabetes. From 2015, not any specific preference, to 2080, where in patients with established atherosclerotic cardiovascular disease and chronic kidney disease, we will choose a GLP-1 receptor agonist or a CGLT2. More studies come to show us the benefit of new medication, and we have here Harmony, Diclertimi, and Carmelina. Harmony with albiglutide show a very important reduce in patients with events, but unfortunately it was taken out from the market. So we arrived in 2019. Where things seems to be more clear, and for patients with established cardiovascular disease is no doubt what we have to choose excuse me, after metformin. Concerning the two studies, Rewind and Pioneer 6, as you see, dulaglutide has also an important or cumulative risk in patients with diabetes, and Pioneer 6 also brings some important data for our patients. So we can say that it is in fact a evolution of guidelines for type 2 diabetes treatment. And in 2019, a guideline on diabetes, pre-diabetes and cardiovascular disease developed by European Society of Cardiology together with ELSD. So key new addition on the year 2090 was that empagliflozin, canagliflozin, dapagliflozin are recommended in patients with type 2 diabetes or cardiovascular disease or at very high risk cardiovascular risk to reduce the cardiovascular events. Empagliflozin is recommended also in patients with type 2 in cardiovascular disease to reduce the risk of death. And liraglutide, semaglutide, dulaglutide are recommended in patients also with cardiovascular disease or very high risk of cardiovascular disease. Also, liraglutide is recommended in patients to reduce risk of death. Saxagliptin is not recommended in patients with type 2 diabetes with high risk of heart failure. But something also changed because in 2030, the first line of therapy was metformin. And in 2090, the European Society of Cardiology recommended that metformin should be considered only in overweight patients without cardiovascular disease or with moderate risk factor. A lot of study will come and show us the benefit from our patients. And instead of conclusion, I can say that we are assisting now to a life revolution of management of patients with diabetes. The paradigm of diabetes type 2 is radically changed from a glucose-centered to a patient-centered approach. So if we want to treat our patient, the wisely choice is the therapy that protects our patients from cardiovascular risk that goes far beyond glycemia. And Galileo Galilei was saying that all truths are easy to understand once they are discovered. The point is to discover them. Thank you very much.